the slides. Okay, let me, because okay, we have to turn it into, okay, do you want to see the slides? Okay.
It would be preferable.
Are you able to see it now?
No, I can see the roof of wherever you are. The ceiling.
Yeah, sorry, you can't see the slides because we can't really it's not set up this way. So the most important thing, we can see you and all of us can see you. Do you mind just start and I help you to forward to the next slides?
Very well. I would assume that I have been introduced, and I'd like to express my regret that I am not present at the meeting because of health issues. So let us carry on to slide number 2. It is very difficult in this short period of time to give a comprehensive overview of what is the most important issue in modern hemophilia care. So when reflecting on this presentation, I decided to focus on 3 specific issues, which are the contributing factors to inhibitor formation, which, as you shall see, I have actually limited severely in my presentation. I will say something about the treatment options for inhibitors, and then I will round off with some comments on cost effectiveness, which is an area which interests me greatly. Can I have the next slide, slide 3?
Sure.
This is a brief, very simple cartonic representation from a recent review by Jan Astermark in Sweden, showing the immune activation of the immune system by factor VIII in patients with hemophilia, which leads ultimately to inhibitor formation. And you can see in a very simplified and extremely summarized form the various components of the immune system which contribute to the generation of antibodies in this instance. You can see the first uptake of factor VIII by antigen-presenting cells, which then process the molecule, present it to T helper cells via class II antigens and receptors to result in the activation of T regulatory cells and the generation of plasma cells and then antibody generation, depending on whether there is a low or high risk. Can I have the next slide, please?
Sure.
Whether there's a low or high risk depends very much on the whole complex of risk factors which you are seeing in this slide here. Please build it up. I need to focus on treatment because, given, as I said, that this is an extremely big subject, I have decided in this very limited period of time, considering the audience being made up mostly of people in the industry, to focus on the issues relating actually to the type of concentrate. I would like to emphasize that in all probability this is in fact a minor component of this vast issue, because we know that issues relating to genetic factors, polymorphisms in the genes, family history, the environment of the patient, the actual severity of the hemophilia phenotype are much more important. But we have been engaged in debate on the question of inhibitor treatment and type of product for many years in this industry. So if I can have the next slide. And this is, please build it up, just build it up until it comes to the last arrows on the recombinant factor VIII half. This is a summary which is updated every few years of the summary of the observational studies in the most instances of inhibitor formation, looking at many populations of patients in many countries given plasma-derived or recombinant factor VIII. And you can see that the basic groups are showing that factor VIII plasma-derived is giving an inhibitor incidence which is roughly half that which is given by the recombinant product. I draw your attention to the large black arrows depicted in both halves of this slide, showing that for both types of product, recombinant and plasma, we have what you might be crudely designating as outliers in relation to the overall incidence. In other words, these two groups of observational studies give us some idea, but it is not possible to get a statistically valid assessment just by comparing these groups. But this is the kind of data which has led to much more analysis in a systematic fashion, and now, thankfully, to some actual clinical trials. So I can have the next slide. This is part of the magnificent Rodin study conducted by large numbers of hemophilia centers around the world and coordinated by the Dutch group centered around Utrecht, Marieke van Berg, Kathleen Fisher, and others. And this is the data from Stephanie Go's MD thesis, which was very unexpectedly published out of the blue 2 years ago in the New England. But in the first instance, observe that in this very systematic prospective, and I emphasize the word prospective study, in large numbers of young patients, there is no significant difference between recombinant and plasma-derived product. We shall look at this slide again in relation to other issues later on. If I can now look at some survey data, this is extremely important. We are thankfully now seeing good survey databases coming into effect, very poorly funded, deplorably so, and I could wish to see them much better funded. Recently there was a workshop at the EMA in London which dealt with some of these issues. And you can see that in this, the EU has data coming from European centers that there is a difference between recombinant plasma-derived. I draw your attention to the first two lines of this slide, but there is no significance in this data. This is a paper published by Kathleen Fisher earlier this year. If I can have the next slide. This is from Massimo Francini and other Italian co-workers. It is a meta-analysis, a very systematic and updated meta-analysis as of 2 years ago, showing again a trend towards an increased risk of inhibitor with recombinant, but observe the overall risk ratio diamond at the bottommost part of the slide. You will see an overlap between the two arms, and therefore again we see there is no significant difference. If I can go to the next slide. This is from a very nice meta-analysis, as with all his meta-analyses, from Alfonso Iorio, and this precedes the Francini meta-analysis, but I thought I should put it in this sequence because it makes a very important point. First of all, the overall meta-analysis showed that there was definitely a significantly higher incidence of inhibitor with the recombinant compared to the plasma-derived product. However, this lost its significance when a multivariate analysis taking into account many of the what you might call confounding factors was put into effect. Alfonso, besides being a clinician, is also a statistical epidemiologist. He is brilliant in this, and he made the point which we always face when we try to analyze clinical data in hemophilia, that these findings underscore the need for randomized controlled trials for the simple reason that the numbers involved were too small to actually be able to extract any statistical conclusion. And therefore, I think at this stage we can conclude that in relation to this issue of the product type, we are in a situation of true clinical equipoise. We are definitely uncertain on the basis of the data, and this justifies on all issues, clinical and ethical, the performance of a randomized clinical study. And thankfully, such a study, kindly build it up, there is an arrow in this slide which is important. Such a study was conceived about 10 years ago by Sandro Gringeri and other Italian colleagues and initiated in 2010 under the current oversight of Professor Manucci and Professor Peivandi in Milan, but involving many other clinical centers, not just in Italy, but throughout Europe. And this is the very important CEPID study on inhibitors and plasma-derived product exposed toddlers. If I can have the next slide. This study is a randomized control trial in which, on the basis of the statistical power required, 270 previously untreated patients have been recruited over the past 5 years and exposed in a randomized fashion according to their clinical needs to either recombinant or plasma-derived factor VIII. You can see the two arms on this slide. You should be looking at slide number 11, and you can see specified over there the types of products in each arm. You can see that on the basis of indications coming from some observational studies, the plasma-derived products all include von Willebrand factor. We will say something about this later on in the presentation. Next slide, please. Kindly build it up to its finish. Okay, so this CPIT study is now complete, and an interim analysis has been performed and reported in various meetings, including the meeting in Melbourne, the Haemophilia Federation meeting in Melbourne last year, and the further update was given by Professor Manucci at the Toronto meeting of the International Society for Thrombosis and Hemostasis recently. Basically, at this stage, we do not have the final result, but we can see on the basis of this slide, you should be looking at slide 12, that an overall incidence of inhibitor compounded of both arms, there is no differentiation here, the blind at this stage is not broken, is 29%. And you can see that when we slice and dice the inhibitor patients, we see the usual expected distribution between high titer and low titer. Can I have the next slide and kindly build it up again to its conclusion? There should be 4 dot points. The Drug Safety Monitoring Board of the CPIT study has made these comments on the interim analysis. This was convened by Lou Aildort, who is the chairman of the board, together with other colleagues. And on the basis of the interim analysis, they conclude that the study is safe to continue and there is no futility issue to stop it from continuing. It is important to keep the data in confidence until the final analysis is complete, but I draw your attention to the final dot point, which states that the absence of futility in the interim analysis means that the original hypothesis of an at least twofold lower incidence of inhibitors with the plasma-derived von Willebrand factor products is still viable and valid. I can tell you that this study will be reported in its entirety together with its final results, i.e. the answer which we are all eagerly awaiting at the ASH meeting, unfortunately in Orlando in December of this year by Pierre Manucci. Okay, can I have the next slide? Back to the Rodin study. Much to our astonishment, 2 years ago, after Stephanie's MD thesis had been published and we thought all the papers had been extracted, this paper came out in the New England Journal, which indicated that when looking at different generations of recombinant factor VIII, a higher than expected and significantly increased incidence of inhibitor was found with one specific product, which was a second generation full-length product. That is, this particular product is still being produced in a milieu which includes human or animal protein. This analysis has also, can I have the next slide, slide 15. This analysis has also been repeated by other groups and I shall go over them, but it is important to note that in the UHAS database, shown here again in Kathleen's paper earlier this year, this observation is not made in effect, although you can see that we have a relatively very small number of patients still given this product, which, given that this is public information through Kathleen's paper, I can specify as Bayer's recombinant. Can I have the next slide? This is now showing the overlap of data between the UHAS database and the various studies which have actually shown that the cogenate helixate product shows a significantly higher incidence of inhibitor versus other third generation factor VIIIs, in this instance Advate. And you can see that the Rodin study, the odds ratio in fact goes up and becomes more significant when we exclude the UHAS overlap, and you can see that the French database shows again a significantly higher incidence, as does the UK Haemophilia Center Directors Organization database. And if I can have the next slide, and this is the conclusion from the paper by Peter Collins on the UK survey, saying that they realized the shortcomings of all the studies. The similarity of the results makes them suggest that clinicians should carefully consider these findings when prescribing recombinant factor VIII to previously unexposed patients. I consider this observation to be extremely interesting and important. We do not have a biological explanation for this observation because no other second generation product, when they were still in the market, because now most of the second generation products are no longer around because we have third generation products, none of them showed this increase in inhibitor. And we do not have a biological explanation, and it is highly unlikely that we will be able to test this situation through a randomized clinical trial. But this is the most recent observation relating product type to inhibitor. May I have the next slide? I would like to now say something more in relation to treatment modality and its effect on inhibitors. Very importantly, we now have several sets of data. Again, this is from the best set, the Rodin study again, from Stephanie's paper in Blood 2 years ago, showing that indeed it is the case that prophylaxis confers a protective effect in relation to inhibitors, and patients on prophylaxis show a lower incidence of inhibitors, and that this is always only observed 20 days after primary exposure to the product. There are other studies, including the Canal study, which was done some 6 years before this particular Rodin. This observation, I think, is extremely important and true. And it led, can I have the next slide? It led to the extremely, I think, exciting for us EPIC study on the basis of the hypothesis of the Bremen group led by Gunther Auerswald, in which the hypothesis intimated that if we try to tolerize the babies pretty soon after diagnosis, prior to the initiation of any severe bleeding event which required large doses of treatment, which we know both because of the danger signal posed by trauma and because of the large volumes of treatment, is a pro-inhibitory stimulus, that if we try to expose the babies before this happens, we can perhaps look towards tolerization and the obviation of inhibitors later on. And the first indications from studies done by Professor Auerswald and his colleagues indicated that this was indeed the case, and therefore a randomized clinical study was initiated in the form of this EPIC study. The next slide, please. I draw your attention, however, to Professor Auerswald's own paper published this year, because the EPIC study had unfortunately to be discontinued because it was very clear that one of the treatment arms was actually leading us to an increased, not a decreased, incidence of inhibitors, and it would have been unethical to continue this trial in its current form, and it was therefore discontinued at the stage where we could see that, in fact, unfortunately, half of the treated subjects, nearly half of the treated subjects developed inhibitors. I am myself disappointed in this because I thought that this was going to be an extremely exciting development. If confirmed, it has not been confirmed. There are in my mind issues relating even here in regards to the product type, which are not yet fully specified, but I do not think that we can ethically continue this kind of study in very young children without the need of actually giving them factor VIII to stop bleeding, given that we run the high risk of inhibitors. Can I now go to slide 21, another very important clinical issue, and this is the question of product switch. We are very well aware that, rightly or wrongly, patient products are switched very frequently, particularly because of tender systems, which always attempt to get the lowest possible price for a given clinical outcome, and this gives us some level of concern in relation to potential neoantigenicity. This is a combination of two publications, one of them another of Alfonso Iorio's meta-analysis on looking at the studies relating to product switch, and the other one by Charlie Hay in Manchester, published just this year. And basically the message from this slide is that looking at the spectrum of studies and combining the results in a meta-analysis, we see no effect on product switch, which gives us some level of encouragement and optimism in relation to when we switch products. I am aware that at the moment a considerably larger study than most of these is being conducted by my own center here in Melbourne by Professor Huyen Tran, and he has the a very interesting perspective of having two product switches on the same population of patients carried out over 5 years. So we will get good data. Can I build up this slide now in relation to tolerization? We know that the modality of choice in relation to obviating inhibitors is immune tolerance induction, and this shows us in regards to the group of Italian clinicians in the PROFIT study that the preferred modality for clinicians is to basically stay on the same brand of factor concentrate which was actually involved when inhibitor was diagnosed, and in fact the vast majority of clinicians, as you can see on this slide, more than 2/3 are using recombinant product. So there is no indication here of a preferential use for plasma-derived von Willebrand factor products. And this is to some extent based upon evidence, because if we look at slide 23, this is a meta-analysis again, published in the British Journal of Hematology, and basically it shows us, and I draw your attention to the overlap of the significance bars between the different groups of product types, that there is no significant difference between von Willebrand factor containing and von Willebrand factor non-containing products. So in relation to ITI, we do not see any of these differences. And this shows us the importance of continuing studies. The RESIST study was initiated some years ago to attempt to answer this question. It was discontinued because of inadequate recruitment in terms of patient numbers. I will finish my talk with some comments on cost effectiveness regarding to modality. If I can have slide 24, this is a cost effectiveness analysis, a cost utility analysis published in Haemophilia earlier this year, on which I and some other clinicians wrote an editorial upon invitation. You can see here that we've got, in the usual cost effectiveness analysis type 3, the three modalities of ITI versus prophylaxis or on-demand therapy utilizing the bypassing agents, and we can see that ITI is infinitely more cost-effective than other modalities. I make this point in emphasis because many authorities are preferring not to fund ITI because it is cheaper over the course of a year to fund some kind of inhibitor bypassing agent rather than tolerize over the whole of life. And given the state of healthcare funding in most countries, especially in Europe, people prefer to solve their problems now rather than worrying what's happening in 20 years' time. But this is extraordinarily short-sighted, as is the case with prophylaxis and normal treatment, as my group showed some years ago. If I can go to the next slide, this is an exquisitely fine recent paper published by Karen Berger, Wolfgang Schramm, and other German investigators. Again, a cost-effectiveness analysis for the situation of inhibitor treatment in Germany. And I salute this paper because this is not just a very good example of using health technology assessment in a good way, but it also shows the benefit of personalized treatment, because the modalities compared in this particular analysis are ITI, on-demand treatment, and then personalizing treatment by ITI between low and high risk patients based upon the kind of clinical parameters which I indicated earlier, which I was not able, because of time, to indicate more strongly. But basically what this shows is that by using personalized ITI, what they call risk assessment based ITI, we get very good cost effectiveness outcomes. And I think this is exactly the kind of data which needs to be generated by the community at large, including this industry, to be able to persuade the cost effectiveness authorities of the importance of funding the treatment. And if I can therefore come to, I think, my last concluding slide, which is slide 26, in relation to hemophilia with inhibitor, I reiterate is the most important issue of our time. A number of risk factors are involved. They are all interacting. There is no such thing as a single solution. And many of the issues regarding the relative risks of the product types are still uncertain. We, however, have indications that this uncertainty may be somewhat ameliorated by the CPET study. We know for a fact that at the moment, although we cannot explain it, one second generation recombinant 8 has a higher incidence in previously untreated patients. I support Professor Collins' statement that this product should be used with great caution. We see that prophylaxis in hemophilia appears to confer a protective effect. However, unfortunately, the EPIC study shows us that this is not observed with early initiation pre-therapeutic prophylaxis. This kind of approach ethically is not justified. Current evidence does not support conclusively, despite many observational studies from particularly France and Germany, the role of plasma-derived von Willebrand factor in ITI. The RESIST trial may inform this issue, but had to be discontinued because of inadequate recruitment. And I reiterate that ITI is the preferred cost-effective modality for inhibitor treatment. I believe I have a final slide to thank my colleagues, Italian clinicians, Chiara Biasoli, Elena Sant'Agostino, Antonio Coppola from Naples, and the father of us all, Professor Manucci, for their generous gifts of slides. And I thank you for your attention and repeat my regret at not being able to be with you in person.